Thank you very much for this kind invitation. First of all, I would like to thank Professor Mohti and Professor Nagler for the honor to be here with you and present this data. The topic of my presentation is donor lymphocyte infusions after allogeneic stem cell transplantation, and I will focus mainly on patients with acute leukemia and high-risk myelodysplastic syndromes. This is the summary of my presentation. I will start with therapeutic DLI. Therapeutic DLI was first, the clinical efficacy of therapeutic DLI was first tested in clinical trials in late 80s and early 90s in patients with chronic myeloid leukemia who had a relapse after a previous allogeneic stem cell transplantation. From these early trials, it was clear that therapeutic DLI was very effective in CML patients, especially for those who relapsed in a chronic phase or in cytogenetic or molecular relapse. Later on, many other studies were performed, were tested the efficacy of therapeutic DLI in many other diseases like AML, acute lymphoblastic leukemia, and high-risk myelodysplastic syndromes. And what comes out from these trials is that therapeutic DLI is much more efficient in patients with low-grade hematological malignancies like CML in chronic phase, where we can observe that the response rate is up to 80%, while it was not so effective in patients with aggressive myeloid malignancies like acute myeloid leukemia or acute lymphoblastic leukemia. And we can see this not only in terms of remission rates, but also in the diffuse, in the disease-free and overall survival, as you can see from these slides. Now I will mainly focus on relapsed AML and therapeutic DLI for relapsed AML. And as you all know, there are no prospective randomized trials attesting the efficacy of therapeutic DLI in the setting of acute myeloid leukemia. So our knowledge comes mainly from large registry studies, single center studies. This is a very important study, comes from the Acute Leukemia Working Party of EBMT. It includes 400 patients with AML that they have the first hematological relapse after allogeneic stem cell transplantation. Patients were divided into two cohorts depending on the administration of DLI for the treatment of post-transplant relapse. So study group consisted of 171 patients who received DLI, while 20 control group consisted of 228 patients who never received DLI for the treatment of relapse. And as you can appreciate for the table here is that these two groups of patients were the baseline, they were well balanced in the baseline characteristics, except the fact that chronic GVHD was more often observed in the non-DLI groups before DLI administration. Now, the main finding of this study was that those patients who receive DLI for the treatment of AML relapse, they had a significantly better overall survival as compared with those patients who never receive DLI as part of the treatment of post-transplant relapse. Now we will focus of those patients who receive DLI. Then we can see that the vast majority of them, 70%, 75% of them receive some kind of cytoreductive therapy before DLI infusion. Most of these patients received the DLI at the time where the disease was active, and most of them receive one or two DLI infusions. The median CD3 cell dose for each DLI was approximately 10 to the 7 per kilogram body weight. Now, the outcome after DLI was, you can see it in the right side of the slides. The complete remission rate after DLI was 35%, while acute GVHD occurred in 43% of the patients, and chronic GVHD developed after DLI in 46% of the patients, and most of them had a severe form of the disease. Now, in multivariate analysis for overall survival, only for those patients who received DLI showed that low blast count, favorable cytogenetics, and most importantly, CR at the time of DLI administration were the most important parameters associated with a favorable outcome and prolonged overall survival after relapse. Now I will move to another presentation, another study, again from, this is a registry study from EBMT. Includes only patients who receive reducing density conditioning during transplant. Only patients with AML were included in this trial that underwent transplant between 2000 and 2008. And 32% of these patients had relapse. So a total of 776 patients were included in this analysis. What we can observe again from this study is that the overall survival at 5 years was only 10% for those patients who had a relapse after transplant. Now let's see what kind of treatments this patient received. And as you can appreciate again from this study, most of these patients received chemotherapy from treatment of post-transplant relapse. Actually, 80% of them received chemotherapy, while many other patients received either DLI or second allogeneic stem cell transplantation as consolidation of remission after donor lymphocyte infusion. Now, regarding the outcome of chemotherapy, it seems that it's really important to achieve CR after chemotherapy, since those patients who had the CR to chemotherapy enjoyed a significantly increased overall survival at 2 years as compared to those patients who didn't respond to chemotherapy. And also now we focus to those patients who had a CR after chemotherapy. Then we can see that those patients who receive consolidation treatment with either DLI or second allogeneic stem cell transplantation for consolidation of complete remission, they had significantly better overall survival as compared to those who never received consolidation with either form of cellular therapy. So again, this is a proof of the principle that the GVL effect of DLI or second allo is really important for the treatment of AML relapse after a previous allogeneic stem cell transplantation. So now in conclusion, the outcome of patients with AML who relapse after previous allogeneic stem cell transplantation is extremely poor. The efficacy of DLI is minimal, especially if administered as single treatment modality in patients with full-blown relapse. Therefore, it is important to administer to our patients some form of cytoreductive chemotherapy in order to achieve leukemia clearance. And the best outcome is observed in patients who achieve CR after cytoreductive chemotherapy and receive donor lymphocyte infusions either for or a second allogeneic stem cell transplantation for consolidation of remission. And now I will switch to preemptive DLI. Preemptive DLI is administered either for persistent mixed chimerism or for positive minimal residual disease. Many previous studies showed that stable mixed chimerism after transplantation is a risk factor for subsequent hematological relapse. And as you can see from these slides in the study, for patients treated for AML in CR, those patients who had a donor T-cell chimerism of less than 85% after transplantation, they had a significantly increased cumulative incidence of relapse as compared to those patients who had a donor T-cell chimerism above 85%. And this was translated into a prolongation of overall survival as well as those for those patients with full donor chimerisms. And this is really clear because stable mixed chimerism after transplantation is a surrogate marker for mutual tolerance between donor and recipient. And this, of course, is synonymous with an absence of graft versus leukemia effect. Based on this knowledge that mixed chimerism is associated with increased incidence of relapse, many study groups tested the efficacy and safety of preemptive donor lymphocyte infusions for the treatment of patients with mixed chimerisms, and almost all of these studies showed the efficacy of preemptive DLI to convert significant percentage of patients from mixed chimerism to full donor chimerism. And also these studies showed that preemptive DLI reduced the cumulative incidence of relapse. This is a single-center analysis study, including 120 patients with AML. These patients, the aim of the study was to assess the efficacy and toxicity of preemptive DLI administered for mixed chimerism. All of these patients receive reduced intensity conditioning before allo and some form of in vivo T-cell depletion for GVHD prophylaxis, either with alemtuzumab or with ATG. Here you can see the CD3 cell dose administered with its DLI infusion, which lower in patients with much unrelated, who receive a graft for a much unrelated donor. The authors administer DLI repeatedly after every 2 months until development of graft versus host disease or conversion to full donor chimerisms, whichever occurred first. And you can see a total of 276 DLI doses were administered, and that was for that the median DLI dose administered to each patient was 2. Now you can see the baseline characteristic of the patients. Patients had AML, MDS, or non-Hodgkin lymphoma. Approximately half of the patients received a graft from a much unrelated donor. And what is important also was that the vast majority of the patients, almost more than 90% of them, they never had acute or chronic GVHD before DLI administration. The median time from allogeneic stem cell transplant to first DLI infusion was day 189, and the median time between subsequent DLI infusions was approximately 2 months. And again, as you can observe here, most of the patients receive either 1 or 2 DLI doses. Now, what about the response rate? 71 out of 120 patients converted to full donor chimerism for an overall response rate of 60%. And it seems that this procedure was safe because although GVHD occurred after DLI administration in 35% of the patients, however, what is important is that only a very low percentage of patients had severe acute or chronic GVHD. Now, another really important finding from this study was that those patients who converted to full donor chimeras, they actually had a significantly reduced incidence of relapse as compared to those patients who didn't respond to DLI and remain mixed donor chimera. And again, you can see that this difference in the cumulative incidence of relapse was translated into a significant prolongation of event-free and overall survival for responders to preemptive DLI. This is another registry study from preemptive DLI from mixed chimerism in patients with acute leukemias, either AML or ALL. This is an EBMT registry study. And again, what is important is that the median CD3 cell dose administered with each infusion was 1 × 10⁶ per kilogram. Again, most of the patients receive 1 or 2 DLI infusions, and all patients were free of immunosuppressive treatment at the time of DLI infusion, and only 10% of them receive some kind of immunosuppression after DLI in order to prevent severe graft versus host disease. Now, regarding safety, you can see that acute GVHD, grade 2 to 4, developed in 12% of patients, and chronic GVHD developed in 30% of patients. However, we have to notice that GVHD, severe GVHD was very low, either acute or chronic. GVHD was very low in patients after donor lymphocyte infusions, and this was translated also into a very low no-relapse mortality of 11% for those patients who received mixed preemptive DLI for mixed chimerism. Now, regarding the efficacy of the procedure, response to preemptive DLI for mixed chimerism was observed in 70% of the patients. And what is also really important is that those patients who converted to full donor chimerism, they have a much better overall survival as compared to those patients who didn't respond to preemptive DLI, and the 5-year overall survival was 76% for responders, while it was only 35% for those who didn't respond to preemptive DLI. Another finding from this study, which is really important to me, is that preemptive DLI for mixed chimerism was associated with a very low incidence of relapse, as compared with the preemptive DLI administered for minimal residual disease, which was significantly higher. And now I'm going also to switch to preemptive DLI for positive minimal residual disease. We know that MRD positive after transplant is one of the most important parameters associated with subsequent hematological relapse, and therefore many groups studied the safety and efficacy of preemptive DLI for positive MRD in patients with various hematological malignancies. And here you can see the most important trials published so far. In most of these trials showed that preemptive DLI for positive MRD was associated with improved outcome and reduced cumulative incidence of relapse for MRD positive patients. This is a children's study including 80 children with AML or ALL. And clearly, it is we can observe here that those patients who were MRD positive after transplant and received preemptive DLI, they have a very low incidence of relapse, and this was translated into a significant prolongation of disease-free survival. On the contrary, those patients who were MRD positive and for various reasons didn't receive donor lymphocyte infusion, these patients have a very high probability of relapse of 63% and very low disease-free survival. However, again, from this study, we have to notice that 12% of the patients develop lethal GVHD after DLI administration. This is another important study that comes from China, including more than 800 patients with acute myeloid leukemia, acute lymphoblastic leukemia, or high-risk MDS. MRD monitoring was performed at regular intervals to all of these patients with multi-parameter flow cytometry and quantitative PCR for WT1 gene. Most of the patients receive graft from a haploidentical related donor, while a much unrelated donor was graft was performed only in 10% of the patients. Now, regarding MRD and DLI administration, patients were divided into two cohorts. Group A consisted of 700 patients who were consistently MRD negative after transplantation, and they didn't receive any intervention, while Group B consisted of 49 patients who became MRD positive after transplant, and they received preemptively low dose IL-2 for prevention of relapse, while Group C consisted of 56 patients with MRD positive disease who received DLI. Now, the DLI given by the Chinese groups, they use the term modified DLI, and this is because donors receive GCSF before DLI collections, and this is there are some studies and some data that shows that GCSF primed, or otherwise called modified DLI, retains significant GVL activity, while the GVHD is the possibility of having GVHD is much lower. Also, in this trial, after DLI, researchers administer some form of immunosuppressive treatment to all patients in order to reduce the incidence of severe GVHD, and the dose of DLI ranged from 1 to 10 times 10 to the 7 per kilogram, depending on the type of donor. Now, what we can observe is that those patients who were MRD negative, as was expected, they had significantly lower probability of relapse as compared with those patients with MRD positive. And another observation was that DLI was much more effective in prevention of relapse as compared to low dose interleukin 2. And this is slides. In these slides, we can see a comparison between the two groups. The group of low dose IL-2 and the group of preemptive DLI. And we can observe here that preemptive DLI was associated with increased incidence of acute graft versus host disease. However, the development of chronic graft versus host disease, as well as the non-relapse mortality, were similar into two groups, IL-2 or DLI. And finally, the most important finding from this study was that DLI was associated with significantly decreased incidence of relapse, and this was translated into prolongation of overall survival in favor of preemptive DLI. So in conclusion, mixed chimerism is associated with increased incidence of relapse. Preemptive DLI for mixed chimerism is associated with a response rate of approximately 70%, and response to preemptive DLI is associated with reduced incidence of relapse. The outcome of preemptive DLI from mixed chimerism is much better than the outcome of preemptive DLI for positive MRD. Preemptive DLI, of course, is associated with increased incidence of graft versus host disease. We don't have many data regarding non-relapse mortality. It seems that it's not substantially increased. And finally, we have to note that the efficacy and safety of preemptive DLI has never been tested in the context of clinical trial. However, it is very popular among most researchers in most centers to administer preemptive DLI for either mixed chimerism or for positive minimal residual disease. And now I will switch to prophylactic DLI. We know that one of the major factors for failure of allogeneic stem cell transplantation, especially for those patients with highly aggressive leukemias like AML or ALL, is the relapse. And therefore, many groups, with the aim to reduce relapse, they tested the safety and efficacy of prophylactic DLI in selected patients with AML, ALL, or high-risk MDS. And you can see these trials here that they had a positive outcome. Now I will like to present you a few data of a Greek study conducted by two academic centers in Athens and in Patras. Our policy is to high-risk patients with AML and MDS, as well as for patients with ALL, is to administer prophylactic DLI. Prophylactic DLI is administered after the 6 months after transplantation, because previous data showed that DLI administered before the 6 months is associated with severe graft versus host disease. Therefore, in these trials performing two academic centers, patients with AML, ALL, or high-risk AMDS underwent allogeneic stem cell transplantation with a similar conditioning. All patients received the same protocol for GVHD prophylaxis, consisted of low-dose alemtuzumab and cyclosporine. And finally, as we can see, at day 180, 63 patients were eligible for prophylactic DLI infusions. Among them, 39 received prophylactic DLI, while 24 patients, they didn't receive DLI for various reasons, mainly because of patient refusal or for logistic due to absence of DLI. So the group of no DLI served as the control group, while those who received DLI served as the study group. And we can see the baseline characteristic between these two groups were very well balanced, as you can see in the slide, in the right side of the slide. Now, the dose of DLI administered was approximately 10 to the 6 per kilogram, and it was administered after day 180, and we give more than one DLI dose at regular intervals. Now, regarding the efficacy, it was from this study, it was clear that prophylactic DLI was associated with a significantly decreased incidence of relapse. It was only 7% in those patients who received DLI, while it was 35% in the group of patients that they didn't receive DLI, and this was translated into significant prolongation of disease-free survival in the prophylactic DLI group. Moreover, something that was really important, the procedure seemed to be very safe, and in a landmark analysis of GVHD observed after the day 180, we showed that late GVHD was similar between the two groups, as well as was the non-relapse mortality. Now I will switch to another study, important study from EBMT. This is again a registry study testing the efficacy and safety of prophylactic DLI in patients with acute myeloid and acute lymphoblastic leukemia. And 105 patients were included in this analysis because they fulfill all the inclusion criteria. Inclusion criteria were that the patient had to be at CR after transplantation, to be in a full donor chimerism with a negative minimal residual disease and free of any immunosuppression. And also a group of 13,000 patients served as control group, and the authors performed a much better analysis. And finally, they discovered 89 matched pairs that consisted the control and the study group. And as you can observe from these slides, the baseline characteristic between these two groups were identical. And when they performed the analysis for the whole group of patients, then they found that there was no difference between prophylactic DLI and control group. However, when they performed again the analysis in the subgroup of patients with high-risk AML, and high-risk AML was defined as AML with unfavorable cytogenetics not in CR at the time of transplant, then they observed that for this subgroup with high-risk leukemia, prophylactic DLI was associated with a decreased incidence of relapse, while non-relapse mortality was similar between the two groups. And finally, this reduced relapse was translated into improved leukemia-free and statistically significant improved overall survival in the patients who received prophylactic DLI. So in conclusion, again, although the efficacy and safety of prophylactic DLI has never been tested in the context of a prospective randomized trial, we can say that from much pair analysis as well from single-center studies, it seems that prophylactic DLI is associated with reduced incidence of relapse in a specific subgroup of patients, and especially for those patients who have a high-risk AML. Of course, prophylactic DLI is associated with GVHD. However, the incidence of GVHD is low, as well as non-relapse mortality if prophylactic DLI is administered at low doses and at least after the day 180 post-transplant. And finally, I would like to stress that prophylactic DLI should be better administered in the context of clinical trials. So there is no doubt that there is a significant benefit from donor lymphocyte infusion under certain circumstances in various hematological malignancies after transplantation. However, most of us were reluctant in administer donor lymphocyte infusion because of the fear of a severe GVHD. In the left side of the slide, you can see the most important parameters associated with GVHD after DLI, and these are conclusions that are based to many previous studies. So what is really important is the timing of DLI after transplant, and the less the time interval between transplant and DLI administration, the higher the possibility of severe GVHD. And another important parameter, of course, is the T-cell dose as well as the degree of donor-recipient mismatch. Therefore, based on this data, EBMT proposed guidelines for the dose of CD3 cell dose included in infused with each DLI in various settings. And you can see that for preemptive DLI, and for those patients who receive it after the 6th month, then for match donors, we can use a dose of 10 times to the 6 per kilogram, whereas for APLO, we have to use a much lower dose, which is 5 times 10 to the 4 per kilogram. And if we administer for the same reason, preemptive DLI, but before the 6th month after transplant, we have to use at least 1 log less CD3 cell dose. And finally, for therapeutic DLI, we are allowed to use much more higher doses because it's important to have a strong GVL effect in order to achieve remission. These are the guidelines also proposed by European Acute Leukemia Working Party of BMT for donor lymphocyte infusion in various settings, either for hematological relapse or positive MRD, or for prophylactically for high-risk disease also. Nowadays, we have to take into account that targeted agents like FLT3 inhibitors, IDH2 inhibitors, or other monoclonal antibodies should be tested also in combination with donor lymphocyte infusions. And finally, I will just want to present you our protocol in Atiko University Hospital for prophylactic DLI. We use prophylactic DLI for high-risk acute leukemias and MDS. You can see here in the left side of the slide, the definition we use for high-risk AML, ALL, and MDS. And our policy is to administer to all patients with prophylactic DLI, to all patients with high-risk disease, to administer prophylactic DLI after the 6th month after transplantation. Exclusion criteria are severe acute GVHD or chronic GVHD at the time of DLI, ongoing immunosuppressive therapy, and also we do not administer prophylactic DLI in those patients who are not in CR of DLI or who are positive MRD at the time of DLI. And I will present you data for 44 patients who had fulfilled all these inclusion and exclusion criteria. Now, regarding our policy, is that we choose a dose of 2 times 10 to the 6 per kilogram. The first infusion is administered after the day 180 for the reason I briefly mentioned before, because the possibility of severe GVHD is low at this after this period of time. And also another important difference from other studies is that we don't use DLI in escalating manner. Instead, we use repeatedly the same dose every 2 months for a maximum of 3 years after transplantation. And the reason for this, I'm going to explain in briefly, is that from previous studies, we have many data from mainly from escalating DLA dosing that showed that the GVHD is associated with the CD3 cell dose in each infusion and not with the total number of CD3 cells infused. Therefore, this is really important because we believe that if we administer the same low dose, then we are not going to have GVHD after subsequent and many administration. Now, on the other hand, we know that as the times after transplantation goes by, then gradually a mutual tolerance between donor and recipient develops, and this is also means that there is no GVL effect anymore. Therefore, we strongly believe that in order to break this mutual tolerance that develops after time, it is important to give repeatedly DLI for prolonged periods of time in order to achieve a sustainable GVL effect. And we use a low dose because we do not want to induce severe GVHD. And this is the rationale of our study. You can see here some of the baseline characteristic of our patients. Limitation of our study is that the vast majority of our patients receive a transplant for a matched sibling donor, and almost all of our patients receive GVHD prophylaxis with low dose gamma. Now let's see the results. And first of all, we can say that the administration of DLI with this technique is extremely safe, because cumulative incidence of acute graft versus GVHD grade 2 to 4 was only 40%, and while chronic GVHD developed in 12%, but severe GVHD, chronic GVHD developed only in 2% of the patients. Now, what is really important is that no case of acute GVHD developed after the third DLI dose. And this is the proof of the principle of what we explained before, that the possibility that the risk of GVHD is associated with the CD3 cell contact in each infusion and not with the total CD3 dose. Now, regarding relapse, we had a very low cumulative incidence of relapse of only 12%, which seems very promising for this group of high-risk patients, and this was translated into a very decent long-term overall survival of approximately 80%. This is an important study from our team, and we are going to keep on working on this. And I would like to thank very much Professor Nagler for his great ideas. He's fruitful for collaboration in this project, not only this project, but in general in many projects that we did together, and for the generosity and the help that he gave us through all these years. And with this, I would like to thank you all for your attention, and I will be happy to take any questions. Thank you very much.
Thank you very much, Professor Tsirigotis, for a really, really beautiful and comprehensive talk. This is probably the nicest talk about DLI I've ever heard. So on behalf of the ICH community, I'd like to congratulate you and thank you. It looks like you managed to share your enthusiasm for DLI, and we have plenty of questions already. It's incredible because on the different list I have, I counted more than 20 questions already. Let's take the first question from Professor Arno Nagler, whom you mentioned, who is my co-chair at the ICH. And his question is whether there is any specific subtype of leukemia, any specific mutation where you feel that DLI might work better. And he has another question also about the role of DLI at the era of targeted therapy for leukemia.
Yeah, thank you very much, Professor Mohty. First of all, for this kind invitation, because it's a great podium to share our ideas. So to be honest, now in the era of targeted therapies, we prefer to use targeted therapies instead of giving a prophylactic DLI, because in any case, even with very low doses of prophylactic DLI, you can have some graft versus host disease. So I think what is really important, the most important parameter is to monitor minimal residual, measurable residual disease. So it's really important to develop very good tools for MRD. If you have very good tools for MRD, then you can rely on MRD, you can give targeted therapies. And actually, in FLT3 positive leukemias, we use either sorafenib or gilteritinib. And in most of the cases nowadays, we don't use prophylactic DLI anymore, except if we see an increasing mixed chimerism. Now, besides FLT3, we don't have experience yet with the IDH1 or 2 inhibitors because they are not yet available in our country. So I cannot say more things about this. And regarding the question about the type of mutations that maybe they are more sensitive or not to donor lymphocyte diffusion, actually I don't have any data. But what I can say is that for TP53 mutations, I think that even prophylactic DLI is not effective, at least from our experience, because we've seen almost all of our patients relapse despite giving prophylactic DLI or everything. So I don't know what about these patients, but finally, for those patients who have targeted treatment, it's better to give maintenance. It's really important. But if we don't have targeted treatment, then we have to be very careful with MRD. It's very important to develop tools for MRD. And if we don't have good MRD, then we have to also to be careful of mixed chimerism. But because also I saw another question here, I have to stress the point that mixed chimerism is not synonymous with MRD. Mixed chimerism means that the patient is and the donor recipient, they are in a mutual tolerance, and this means absence of GVL. So therefore, this is a surrogate marker for increased risk of relapse. It's not the same with MRD. MRD is really bad. If you have MRD and you believe this is MRD, then the patient is going to relapse.
Thank you very much. Very comprehensive answer. We have another question from Dr. Teresa Coman from the Institut Gustave Roussy in Paris, in France. And she's thanking you for your nice talk. And her question is about comparing GCSF prime DLI versus conventional DLI. What are your thoughts in terms of efficacy, safety, and the way you should use it?
Well, these data are coming mostly from China. In China, they use they call it modified DLI. And the basic idea is that GCSF administration somehow converts T cells to T helper from T helper 1 to T helper 2. And there is a less possibility of having acute GVHD. I'm not sure if this is the case, but okay, this is the only explanation I have. There is no comparison between modified DLI and standard DLI. But in our center, for those patients who relapse after transplant with acute leukemias, then we use chemotherapy and we use modified DLI, not because we strongly believe that we have less GVHD, but we also because we accelerate the hematological recovery and we have less infections.
Excellent. Thank you very much. We have another question from Dr. Martin Schumacher, and his question is about whether, because you alluded several times to the risk of GVHD after DLI, and do you believe GVHD after DLI is different from the classical GVHD, whether acute or chronic, or it's just boosting GVHD?
Yes, actually, I believe it's not the same. If you follow the EBMT guidelines regarding the dosing and the timing, most of the times you don't see really severe GVHD. And to be honest, we don't have deaths from GVHD after DLI, except if you use, huge doses. Also, it's very, very often you can see overlap syndromes after DLI. You don't see the classic GVHD. It's more often to see overlap syndrome. Signs of classic acute with concurrently with signs of acute chronic, of classic chronic. So this is different. But in general, it's in most of the cases it's well controlled. And also, if you use a short course of low dose cyclosporine after DLI, most probably you reduce the incidence of GVHD without losing much of the GVL effect. But again, this is something that you have to test in clinical trials.
Excellent. Thank you very much. Again, very thoughtful. We have a question from Dr. Cynthia Pelayo, and this is about DLI in the setting of poor graft function. And I will try to broaden the question is whether you would use DLI, for instance, in a situation of poor graft function, or if you have to use a boost, a CD34 boost, would you rather prefer selected stem cells, or you just give the full non-selected, non-manipulated product?
No, I agree absolutely with you. In these cases, if we have a poor graft function, then we have to exclude the possibility of immunological rejection. For this case, we use chimerism in CD3 cells. It's very rare to have rejection, immunological rejection, if you have a full donor in CD3. So if then we try to find other reasons for poor graft function, like CMV, other infections, and finally, if we don't have immunological rejection, 100% we prefer to give a boost of CD34 selected cells.
Excellent, thank you. Another question, and I'm sorry, Panagiotis, plenty of questions. You're very popular tonight. Dr. Moritz Reichert asking whether you would be willing to combine a prophylactic DLI with prophylactic ruxolitinib, because we know ruxolitinib is a good treatment for GVHD. So I guess the spirit of the question saying, okay, I can prevent GVHD while taking advantage of DLI. What do you think? Is this something feasible? Are there any reports? What's your experience?
I think it's a good idea, but to be honest, I never did it so far. But it's a nice idea, I think. But I don't.
Okay. But there is experience in the literature where you can give DLI plus cyclosporine. And
yes.
There are pro and cons.
Yeah.
We have another question here. Do you believe DLI after haplotransplant and post-Cy different from any other DLI activity?
Well, we have to be very, very careful with the dosing. This is what we use also prophylactic DLI in high risk even after haplo, to be honest. But we use very low doses. And if you use low doses, then I think it's the same. It doesn't make any difference with with other DLI in the setting of match unrelated donors or in match related donor.
Excellent. So we have a question from Dr. Esteban Arrieta Bolanos, and this is specific to the haplo setting, whether you consider the potential loss of the mismatch HLA in this setting, and what would be its impact on the efficacy of DLI?
Well, in this situation, usually you see this in case of over the relapse. I mean, if you use it in the preemptive setting for MRD, or if you use it for prophylactic reasons, then you don't have any way to discover if you have a minimal clone of leukemia with an haplotype loss. You can never. I don't think that there is any technology that you can see this right now. So you see haplotype loss only in cases of full-blown relapse. In this case, it's really wise to see if there is a loss of haplotype, because most probably if you try to give therapeutically DLI, it will not be effective.
Okay. We have another question about the DLI product itself from Dr. Oliver Perea, and there is another question, so I'll combine both questions. Is about the heterogeneity of the product. So do you see a way to have a sort of a standardized DLI product? And the other question we had is about whether depletion of Tregs from the DLI product is useful, and what are the risks, and what's your recommendation today, I would say, if you want to develop DLI as a drug, as a standardized drug?
Well, as you know, in the past, this is the holy grail of immunotherapy to try to separate GVL from GVHD. I think this is really important, but it's. I think it's. I cannot see this, in tomorrow or the day after tomorrow. So. Actually, the effect against leukemia, we have to see what type of antigens we have. So we have the HLA in case of HLA mismatch. We have the minor antigens. And if you remember, there was a great story for those minor antigens that are hematopoietic tissue restricted. This is a very nice story, but I don't have any new data from this, because actually if we discover this hematopoietic restricted minor, then if you try to select these specific T cells, then you can have a GVL effect without GVHD. But I'm afraid that there are no data in everyday clinical practice so far. This is really important. Another important thing is to use, as they did it in Baylor, as you know, but they do this for the treatment of over relapse. You can manipulate T cells by using peptides for PR1, PRAME, NY-ESO, and also WT1 antigen. And so you can use this, the name of these are leukemia-associated antigens. So you can create a DLI which will be specific for these targets. And this is somehow you can have some GVL, not so strong, but without GVHD. Maybe this is a nice idea to do this. And they did it, by culturing donor T cells with peptides and making these T cell products. And they had very good responses to patients with full-blown relapse, but I'm not sure if these responses lasted for long. So this will be a nice idea in the prophylactic setting.
Thank you. Another question a practical question, actually, from Dr. Teresa Coman from France. And this is whether, if you have to do DLI for MRD positivity, would you recommend tapering first the immunosuppressive treatment before DLI, or would you just give DLI?
Usually we do them concurrently, because if you believe this MRD, because sometimes, with multi-parameter flow cytometry, to be honest, you never be sure. But if you believe, if you have a molecular method like in NPM1, then yes, because now we have many great experience with the cutoff in our lab with NPM1, Then in this case, we use cyclosporin and we use also DLI.
Okay, fantastic. If you allow me, we still have 3 minutes, and then I will stop the questions. I do apologize, guys. You are very prolific today with your questions. So we have a question from Dr. Mohammed Baloura about DLI in children. What is the current experience and recommendations, if you are aware of? Because I know in children, the indications are slightly different.
To be honest, I'm not involved in children, so I would prefer not to give because really I don't know. I mean, I don't have experience with children.
Okay, so now we have a more tricky question, and I don't know whether I understood exactly the question, but I will, I would say, translate it differently. And this is a question from Dr. Mike Radford. And assuming we have an ALL patient who got transplant, relapse after transplant, you gave CAR T cell, and let's say the patient failed, the disease relapsed after CAR T cell. Would you consider DLI after these CAR T cells? It becomes like a sort of a ménage à trois,
Now, if in ALL, if the patient relapse and you have full-blown relapse after allo, it's really, really difficult to save the patient with DLI. But any way you can test this, but it's better if you try to do this in the MRD setting than in full-blown relapse. And now you know that there are some technologies that you can have very nice MRD testing in ALL so deep as I think at the level of 10 to the -6.
Wonderful. This has been a fantastic webinar. Thank you again so much, Professor Panagiotis Tsirigotis. I hope I'm pronouncing well.
Yeah.
It has been a pleasure having you with us at the IACH. And thank you all for joining us. It has been quite incredible, including all of these questions. I do apologize that we were not able to take all the questions. I'm sure you can reach out to Professor Tsirigotis to get more details. But for
And I would like also to thank you very much. This is a great job that you do with these webinars, and it is really my honor to be with you.
Well, thank you very much for your contribution, for volunteering to our vision of hematology without border.
It's a great job, yeah.
This is the International Academy for Clinical Hematology around the globe and across the hematology field. Take care.
Thank you. Bye.